السلام عليكم ورحمة الله وبركاته. مساء الخير جميعا. First of all, I would like to thank you all for your attendance today and the last 2 days. Today, inshallah, we have 3 interesting topics. We will begin with breast cancer, then we will go for colorectal, and we will end up with lung cancer. Our first speaker today is Dr. Ashtiyaq Bajneh. She is oncology clinical pharmacist and head of a clinical pharmacy department and in King Abdullah Medical City in Mecca. Welcome, Dr. Ashtiyaq, and you can start.
شكرا دكتور عبد الرحمن، وإن شاء الله تكون المحاضرة خفيفة رغم إنها breast cancer بس interesting. واضحة؟
أي نعم دكتورة، واضح.
بسم الله الرحمن الرحيم. I will start by I have no financial disclosure to disclose. So الoutline هنبدأ نتكلم عن introduction, general statistic and anatomy of the breast and how breast cancer can affect that anatomy. بعدين we will go through risk factor, just a quick review على diagnosis with screening, also prevention والstaging، وطبعا حيكون المين focus على treatment modalities والmanagement. So the introduction first, worldwide breast cancer account to 11.6% من total cancer cases. محتل المركز الثاني عالميا. في السعودية the percentage is a little bit higher, around 20% عندنا في السعودية. بالنسبة للمورتاليتي however في يعني around the world it's about 6.6%. فمحتل المركز الخامس عالميا في المورتاليتي، بينما في السعودية التاسع across يعني كل ال other cancer. لو لاحظنا هنا إنه في السعودية أغلب البيشنتس اللي بيجيهم breast cancer incidence يكون في ال early ages من 24 to 34 age. this is good إنه ممكن يكونوا الأغلب بيكون من بدري الاكتشاف، وإذا كان البرسنتج غير أو يعني كانوا advanced على طول، this is also a bad prognosis. So بين الاثنين. general anatomy طبعا البريست متكون من tissues اللي هي fat tissues، ومتكون من اللي هي loops، واللوبس داخلها glands اللي هي اللوبيولز اللي هي المسؤولة عن production of milk. و through the ducts طبعا الملك بيحصل له transportation to outside breast for breastfeeding. في يحيط هذا التيشوز طبعا زي ما قلت لكم fat tissues, adipose tissues and connective tissues, ligaments, يعني also vascularity. و the most important thing is اللي هو lymph nodes اللي حيكون له role in the breast cancer also. فالبريست كانسر زي ما احنا شايفين هنا هذا بالنسبة للدكت، وسيميلرلي اللوبس حتكون أو الليبيولز تكون عبارة عن epithelial cells مبطنة على شكل تجويف. this tissue أو this cells, these cells if it start to have certain carcinogenic mutations we reproduced، بالتالي حتصير عندنا kind of cancer but it's contained. في هذا الوضع نقول له in situ أو non-invasive cancer، فيكون مثلا زي ductal carcinoma in situ، similarly في lobular carcinoma in situ. فهذه non-invasive types of breast cancer. Once إنه these cells invades ال surrounding tissue سواء كانت الفات tissues أو السكن خرجت على برا، فهذا ينتقل بكذا من النون invasive للinvasive breast cancer. وعلى حسب السايز of the tumor حيكون early stage أو locally advanced disease. once أنه هو انتقلت هذه cancerous cells to other organs أو to other شو اسمه tissues، إذن حيكون عندنا metastatic breast cancer. البايوماركر associated with the pathology of breast cancer غالبا يكون عندنا الهرمون ريسبتورز، ودائما نطلق عليها أو يعني نرمز لها ب HR. غالبا تكون عندنا الاستروجين اللي هو الاي ار والبروجستيرون بي ار. فهذا account ل around 80%، أكثر من 80% من البيشنتس يكون عندهم هرمون receptor positive breast cancer. The other very important biomarker اللي هو ال HER2 Human Epithelial Growth Factor Receptor 2, which is very important, account ل around من 15 to 20% من population يكون عندهم HER2 diseases. الأذر هذه البراكا، البي دي ال، البيكا 3، الانتارك، MSI هاي، هذه كلها newly introduced to the guidelines. بدأوا الناس دحين يطالعوا في هذه البايوماركرز to implement أو to find new cures عشان تكون targeted to those medications. فهذه يمكن في خلال ال5 سنوات اللي فاتت بدأت شركات الأدوية تكتشف أدوية targeting those kind of نقول biomarkers أو genes، وبالتالي تساعد السب تايبس هذول البيشنت اللي عندهم مثلا براكا بوزيتيف أو بي دي ال بوزيتيف، بحيث إن هم ياخذوا more benefit of the treatment. الريسك فاكتورز عندنا يا تكون hereditary يا اما تكون risk factor general to all patients. البيشنت ينقسموا لنورمال بيشنت average risk، عندهم كل البوبوليشن يكونوا عبارة عن average risk، وفي بعض البوبوليشن أو سب جروب من البوبوليشن يكون عندهم increased risk. فهذول البيشنت غالبا يكونوا عندهم hereditary breast cancer، من 5 to 10% من البيشنت يكونوا عندهم BRCA1 أو BRCA2 tumor suppressor gene. أحيانا around 1 to 5% من البيشنت يكون عندهم TB53 tumor suppressor gene. in less extent ال PTN. البروجريسيف جين طبعا زي ما قلت لكم من 15 around 20 ل 25% للHER2. الأذر risk factors اللي هي increased age, ethnicity, race والفاميلي هيستوري طبعا characteristic relative أو personal history. يعني لو في female she had breast cancer before in one breast, then the chance إن هي يجيها in a contralateral breast cancer is higher طبعا. Endogenous exposure للإستروجين سواء كان endogenous أو exogenous، يعني سواء كانت ب oral contraceptive hormonal therapy أو كان عن طريق إنه هي they reached المنارك at younger age less than 12 years of age، أو they got older age at menopause. اللايف ستايل سواء كان increase body mass index، physical activity، الالكول consumptions، كلها هذه بتزود الريسك اوف كانسر. في فاكتورز بالعكس بتقلل الريسك اوف كانسر اللي هي الاكسرسايز، البريور اوفركتومي طبعا اللي هو الاستئصال المبايض before the 45 years and breast cancer breastfeeding and prior risk reducing surgery سواء by ovary removal أو by اللي هو total mastectomy. diagnosis and screening عندنا زمان طلعت فترة كذا إنه كل الناس يقولوا لازم تعملوا breast self examination on a monthly basis، وهذا بعدين في النهاية طلعت study very large study تقول إنه this kind of examination breast self examination is not يعني related to any mortality, does not affect any mortality, they drop it out of the guideline. The one that we should يعني في البيشنت اللي عندهم high risk at high risk, they have to do clinical breast exam. So one trained physician should do that. Ultrasound, بعدين ينتقل للماموجرام which is the best. هذه صورة الماموجرام is the best option for the diagnosis. بعد كذا إذا كان في findings في الماموجرام then we go to biopsy، سواء كانت needle core أو excisional. إن إحنا needle core إن إحنا بس ندخل needle ونطلع جزء أو يعني عينة من التيومر، بينما الاكسجين اللي احنا بنشيل التيومر كله وبنعمل له biopsy. طبعا هذه حتكون just for the small part of cancer. بعدين عندنا breast MRI في المور advanced cases، CT وسكان الهول بودي والبون سكان، هذه في حالة الميتاستاتيك كانسر. طيب البريفنشن احنا عندنا البروفلاكتيك ماستكتومي بايرت يا اما للبيشنتس اللي هم طبعا عندهم هاي ريسك نعمل بروفلاكتيك ماستكتومي، يعني من غير ما يكون عندهم كانسر they can choose ان هم to remove both the breasts عشان ما يجيهم breast cancer later on، او bilateral oophorectomy اللي هم removal of the ovaries، او endocrine therapy for 5 years بعد كده ممكن. طيب بالنسبة للستيجنج عندنا الستيج، عندنا ستيجز، ستيج 1 في عندنا طبعا على حسب التي ان ام. التي اللي هو tumor size، يبدأ من طبعا إنه هو not invisible no evidence for tumor T0، أو TIS اللي هو يكون موجود بس يعني cannot be يعني distinguished أو assessed by normal methods. وبعدين T1 يكون 2 centimeters 2 to 5 centimeters أو above أو أكثر من 5 centimeters. ال N عبارة عن النود الليمف نود involvement سواء كان فيه أو غير موجود وحددها وكذا. الام سواء كانت M0 يعني ميتاستاتيك أو نون ميتاستاتيك. فعلى هذا الأساس إحنا بنصنف stage 0 1 1A 1 2 B and 3 و 4. طبعا الكانسر البريست كانسر mainly metastasized أو most common metastasis sites اللي هو البون، البرين، اللنج والليفر. طيب let's see the management of breast cancer. طبعا احنا عندنا treatment modalities، عندنا surgery which is the gold standard ان احنا we go directly for surgery in all stages ما عدا اللي هو الستيج الميتاستاتيك اللي هو آخر ستيج. فغالبا احنا بنعمل يا اما lumpectomy او total mastectomy combined by radiation in most of the modules، سواء كان whole breast radiation او partial radiation. بعد كذا يكون عندنا chemotherapy. In some settings we use chemotherapy as neoadjuvant، ومعناته neoadjuvant which is pre-operative. الهدف من neoadjuvant treatment ان احنا نستخدمها قبل any surgery to reduce the tumor size عشان نسمح بان احنا نقدر نشيل التيومر. In some setting يعني زي مثلا لو كان عندنا lymph node involvement يكون الهدف من النيو adjuvant هذا increase survival. Also النيو adjuvant therapy بيسمح ان احنا بدل ما نعمل total mastectomy نشيل كل البريست، لا نعمل lumpectomy، وهو يسمح لنا ان احنا نقلل السيرجري intensive. بعد كده عندنا الادجuvant which is after السيرجري we will start giving chemotherapy أو حتى endocrine therapy أو targeted therapy after، وهذا يسموه الادجuvant therapy يعني بعد. وآخر حاجة الباليشن اللي هو لما يكون احنا فقط we want to palliate يعني نرفع شوية، فمعناته نرفع شوية من الألم أو من حدة الديزيز، فهذا الباليشن therapy. So we can use palliative therapy and palliative chemo, palliative endocrine أو any of these medications لما يكون عندنا metastatic end stage disease. طبعا غالبا في الكيموثيرابي يكون anthracycline هم الباك backbone الانثراسايكلين والتاكسانز حقينا هم most common two categories that we used in breast cancer. بالنسبة للإندوكراين ثيرابي احنا عندنا 3 categories أو 3 subgroups اللي هم ال selective estrogen receptor modulators واللي هم ال aromatase inhibitors و selective estrogen receptor down regulators. أنا حطيت ال CDK4/6 inhibitors على أساس إن هم they are not endocrine therapy per se. They do not work directly على الendocrine receptors على estrogen receptors, but however they are used in the treatment of hormonal positive breast cancer. That's why إن أنا حطيتهم هنا. بس هم يكونوا more يعني حقهم ممكن الكاتيجوري يكون يا إما targeted أو miscellaneous. targeted therapy طبعا زي ما قلت لكم في الأول إنه based على whatever we are going to extract من البيوبسي as a pathology، سواء كان حللنا طلع إن patient عندهم HER2 positive، BRCA1 or 2، BDL، NTARC، whatever كان نوع المutations اللي موجودة عندها عند التيشو هذه، فبالتالي we start targeting it by targeted therapy that will focus on that mutation. هذه كذا صورة سريعة تجمع كل الميكانيزم of actions. We're not going to talk يعني a lot about it، بس الفكرة إنه إحنا عندنا الإستروجين. This is a very يعني module very pathway لحاله كذا شغال اللي هو الإستروجين receptors and how we can stop it سواء by يعني slowing the progression production of estrogen أصلاً أو blocking receptors أصلاً من إنهم يستقبلوا any estrogen أو إنه by other targeted therapy سواء كان monoclonal antibodies أو كان على more of the structures inside the cells نفسها. راح ناخذ واحد من الموديولز هذه عشان لما نتكلم في الأخير عن ال steps in the therapy يكون عندنا فكرة واضحة. So first we will start with endocrine therapy. الendocrine therapy عندنا selective estrogen receptor modulators اللي هو غالبا التاموكسيفين. في other يعني أخوات له، ولكن this is the most common used واللي موجود في الماركت بشكل أكبر. يستخدم في البريمينوبوز and postmenopausal. The one big يعني issue with tamoxifen اللي هو drug interaction عنده اللي هو cytochrome B2D6 substrate، هو substrate، ويتحول التاموكسيفين من تاموكسيفين إلى active metabolite by D2D6. فبالتالي any strong inhibitor سواء كان ال SSRIs أو any other strong inhibitors حتأثر في ال efficacy of tamoxifen. Also الوارفرين is a substrate فيصير في competitive inhibition للوارفرين، فممكن يصير عندنا يصير الوارفرين بالعكس أكثر موجود في الجسم وبالتالي حيصير bleeding. Those are two main concerns we have to يعني look for them. كثير من البيشنتس اللي يكون عندهم breast cancer يكونوا على SSRIs سواء كان for treatment of hot flashes أو for just depression. من السايد افكتس حقتهم الهوت فلاشز واحيانا يقولوا لها tamoxifen flash, bone pain, and one of the most يعني نقول serious side effects اللي هي endometrial cancers, or sometimes it can increase the mortality due to endometrial cancers. Cataract and VTE primary يكون BE، وغالبا هذه الأعراض كلها تكون في البيشنتس اللي هم more than 50 أو postmenopausal. aromatase inhibitors عندنا انسترازول، ليترازول، واكستامستين، طبعا كلهم موجودين في الماركت and you can see them, and sometimes بالذات الانسترازول والليترازول لأنهم non steroidal فيكونوا يعني interchangeable. أحيانا بيحطوا البيشنت على الليترازول شوية بيغيروه على الانسترازول على حسب الافيلابيلتي. بعدين هذول طبعا كل aromatase بيستخدموا post menopausal، ما بيستخدموا pre-menopausal for many reasons. طبعا هم مو يعني generally ممكن نقول ان هم يشبهوا التاموكسيفين in kind of efficacy, but they are more effective. In some trials, they have been proven إنهم more effective. However, عشان السايد افكت حقهم اللي هو البون density loss يؤدي إلى osteoporosis and fractions, we usually don't use them in premenopausal patients. We use them only in postmenopausal patients. Also عندنا اللي هي الميديكال ovarian suppression therapy اللي هو ال LHRH luteinizing hormone releasing hormone inhibitors اللي هو الكازولين والليبرلايد يستخدموا for premenopausal women to suppress the ovarian production of estrogen عشان يساعد بحيث انه ما عاد يكون عندنا اي استروجين يغذي البريست كانسر with fuel to grow. فاول هذول يعني سواء نحن استخدمنا selective estrogen receptor modulators او aromatase inhibitors او حتى endocrine therapy later on, we have to use في ال premenopausal we have to use ovarian suppression therapy. بعد كذا احنا طبعا عندنا selective estrogen receptor down regulator وهذول الفلفاسترين يستخدم غالبا في second line او metastatic setting. طبعا ممكن يعمل thrombocytopenia and liver impairment وهذول الميديكيشنز كلهم contraindicated in pregnancy and they are teratogenic. فالبيشنتس اللي بياخدوهم لمدة 10 سنوات و20 سنة 10 سنوات 5 سنوات they have to be on oral contraceptive or be very cautious. طبعا most common side effect injection site pain و nausea vomiting bone pain و fatigue hot flashes. عندنا CKD4/6 inhibitors palbociclib, ribociclib, abibaciclib they are new ويستخدموا في الادفانس metastatic cancer. طبعا most common side effect لهم كلهم نيوتروبينيا وغالبا بغير الدوزز according to neutropenia. يكون عندنا QTC prolongation ممكن تكون associated مع palbociclib and ribociclib together بس أكثر مع الريبوسيكليب وديارية وجي آي discomfort غالبا تكون مع البيماسيكليب. ثاني مديول اللي هو الكيموثيرابي. طبعا الكيموثيرابي احنا عندنا انترا سايكلين بيزد وتاكسام بيزد وهذه يعني just examples of all the regimen that we can use سواء كانت انترا سايكلين بيزد او تاكسام بيزد. وعندنا اللي هو historically كان بيستخدم CMF وحاليا بيستخدم CMF only for patients اللي هم عندهم cardiac toxicity من الانثراسايكلينز فنقدر نستخدم لهم CMF. بعد كده عندنا الانثراسايكلينز اللي هم دوكسيروبسين والايبيروبسين. السيفير سايد افكت حقتهم تكون سيفير مايلوسبريشن عشان كذا دائما نستخدم معاهم supportive GCSF nausea و vomiting طبعا. Also one of the most common مو common بس يعني serious side effects من الانثراسايكلينز الكارديوتوكسيسيتي و it's a dose related. ال cumulative lifetime limit dose تكون 450 بس تبدأ توكسيسيتي تظهر ممكن بعد 200 ملغرام بير متر سكوير فتبدأ يكون في more regular monitoring بعد 240. Exacerbated by concomitant administration of radiation therapy and other cytotoxic drugs زي trastuzumab اللي هو also another medication that we commonly used here. The prevention يكون continuous slow infusion of doxorubicin أحسن من إن إحنا نعطيها single bolus واستخدام الليبوزومال doxorubicin بيقلل also الكاردياك toxicity. في عندنا antidote is doxorubicin ولكن يعني rarely بيستخدم و very vague how we can start using it. ثاني حاجة التكسان عندنا باكليتاكسل دوسيتاكسل نستخدمهم weekly وفي regimens ممكن نستخدم لهم Q every 3 weeks. يعني لها دراسات ومن اللي أحسن ومن اللي أفضل. It's very complex ما حنتكلم فيها دحين. السايد افكتس غالبا تكون هايبر سنسيتيفيتي وريليتد للانفيوجن رياكشن، فنستخدم بري ميديكيشن. بعدين عندنا also myelosuppression وغالبا تكون مع دوستاكسل اكثر، نيوروتوكسيسيتي وهذه تكون delayed و associated with higher doses. Also they potentiate الكارديوكسيسيتي حقت الانثراسايكلينز والتراسوزوماب. ممكن في other regimens اللي هي ممكن السايكلوفوسفامايد بيستخدم مع الريجمنز بيؤدي إلى myelosuppression. وعندنا الكاربوبلاتين جنزايتوكين also. التارجتد ثيرابي اللي هو الهرمونال ثيرابي بنستخدم تراستوزوماب أو أدوتراستوزوماب. وفي subcutaneous formulation للتراستوزوماب بيستخدم غالبا تراستوزوماب for 1 year to 2 years as an adjuvant therapy وأحيانا as a neoadjuvant. طبعا بيسبب كارديوتوكسيسيتي، هي أكثر شيء اللي احنا بنخاف منها. البرتوزوماب بيستخدم as combination usually مع ترستوزوماب as monoclonal. في عندنا بارب انهبيتورز اللي هم اولابريب وتلازريب، وهذول بيستخدموا غالبا للبيشنت اللي عندهم براكا. تشيك بوينت انهبيتور اللي هو الاتيزوليزوماب يستخدم للتريبل نيجاتيف بريست كانسر مع الباكليتاكسل. وهذه التارجت ثيرابي الاخرى بتستخدم list commonly في البيشنتس اللي عندهم ميتاستاتيك و advanced cancer. طبعا سريع كده بس هناخد كل stage of the disease و how can we treat it. اللوبولار كارسينوما ان سيتو حيكون في الهاي ريسك patients. هو غالبا اللوبولار كارسينوما ان سيتو is not a cancer state by itself، بس هو high risk status for developing breast cancer. Around 20% من ال patients they will develop cancer in the 20 following years. فبعد الاكسجينال بايوبسي، بعد ما يشيلوا كل اللوبولار كارسينوما ان سيتو هذه اللي موجوده هناك، they can observe it's associated with 21% يعني recurrence أو development of invasive cancer. بعد كده ممكن نعمل reduction risk reduction therapy. فهذا يعطينا additional 56% risk reduction إن إحنا يجينا breast cancer after that. فيكون بإندوكراين ثيرابي زي الموديولز اللي أنا قلت لكم، هو تاموكسيفين أو أروماتيز انهبيتور على حسب البيشنت إذا كان بريمونوبوز أو بوست مونوبوزال، ويكون for 5 years. Some patients they will prefer إنهم يعملوا bilateral mastectomy which is يعني kind of aggressive treatment إن إحنا نعمل حاجة زي كذا in not even cancerous patients. طيب في هذا الكيس إذا تقدروا تدخل على الكيس. طيب good. الجواب صحيح، تاموكسيفين أغلبكم جاوب. طيب فهذه البيشنت is premenopausal، فغالبا احنا حنستخدم مع البريمونوبوزال تاموكسيفين، ما حنستخدم اللي هو aromatase inhibitor. that's good. طيب في الدكتور كارسينوما in situ we will treat the patient with lumpectomy أو total mastectomy. غالبا إذا عملنا lumpectomy حنعمل radiation، يعني ما شلنا كل البريست، حنعمل lumpectomy مع radiation و endocrine therapy. أوكي. الاندوكراين ثيرابي غالبا يكون for 5 years و it's definitely indicated for patients اللي عندهم hormonal receptor positive. We still use it in patients اللي عندهم hormonal receptor negative, but it's questionable about الافيكاسي حقها. في early stages breast cancer usually طبعا as always ان احنا نبدا بالسيرجري والهدف من ان احنا نعطي نيو ادجuvant ثيرابي هنا ان احنا نقلل الحده حقت السيرجري من توتال ماستكتومي تو لمبكتومي. فبنستخدم هذه one option او one advantage من نيو ادجuvant. الثاني شيء ان احنا لو البيشنت عندها nodes lymph node involvement وقتها we have to use radiation therapy also neoadjuvant therapy. فالنيو adjuvant systemic therapy حيكون عندنا غالبا anthracycline based زائد taxane based تكون for a total duration of تقريبا 12 weeks. وبعد كذا نعمل السيرجري ونستخدم الادجuvant ثيرابي على حسب ايش نوع التيومر عندنا. اذا كان HER2 بوزيتيف راح نستخدم ترستوزوماب بلس اور ماينس بيرتوزوماب على حسب حجم التيومر. and HER2 اذا كان HR او هرمونال بوزيتيف هنستخدم endocrine therapy for 10 years. وهنا طبعا يختلف على حسب pre-menopausal post-menopausal status. في اللوكالي ادفانس بريست كانسر برضه نبدا سيرجري وراديشن. والراديشن هنا is a must regardless of the type of the surgery سواء كان ماستكتومي او لمبكتومي. بعد كده حنبدا نيو ادجuvant طبعا مو بعد اول شيء نيو ادجuvant systemic therapy بعدين حيكون السيرجري بعد كده. ففي اللوكالي ادفانسد بريست كانسر حنبدا بالنيو ادجuvant. كل الكيموثيرابي يكون بريور سيرجري يكون نيو ادجuvant عشان نحاول نحن نقلل من التيومر بيردن اللي موجود عندنا. بعد كده حنستخدم انثراسايكلين زائد تاكسان بيز ريجيمن يكون الاثنين موجودين. وفي الهير2 تارجت ثيرابي حنستخدم في الهير 2 بوزيتيف هنستخدم هير 2 تارجت ثيرابي والاندوكراين ثيرابي اذا كان عندنا اندوكراين اتش ار بوزيتيف for at least 9 weeks والماكسيمم يكون 14 weeks بالنسبه للهير 2 ترستوزوماب. وممكن نوصل ل 18 week. sometimes we can do adutrastuzumab after trastuzumab اذا ما وصلنا ل resectable diseases اللي احنا نبغاها. بعد كده ممكن نستخدم adjuvant systemic therapy HER2 إذا كان عندنا HER2 positive and endocrine therapy إذا كان عندنا endocrine positive patient the same way. Finally الميتاستاتيك recurrent breast cancer طبعا الهدف منه palliation ما عاد هنا في أي cure. We still do surgeries إذا كان for palliation purposes يعني to reduce the pain, reduce the burden of the disease انتشاره لأماكن تانية. We might do surgery وإذا كان عندنا localized metastases يعني موجود في اللنج بس localized ما هو منتشر مرة we can do a surgery here. بالنسبة للسيستميك ثيرابي also chemotherapy غالبا نستخدم combination but إذا كان البيشنت fragile هذا ممكن نستخدم single agent but preferably إن إحنا نستخدم combination. في ال HR negative بنستخدم كيموثيرابي أو إذا كان في عندنا extreme low level of estrogen أقل من 1% sometimes أقل من 5% they will still use الكيموثيرابي. الانديكيشن also إنه يكون عندنا البيشنت symptomatic من الديزيز الميتاستاسيس ديزيز أو يكون visceral involvement اللي هو مثلا colon cancer مثلا stomach cancer زي كذا يكون في involvement للvisceral organ. أو يكون عندنا life threatening disease فنبدأ على طول كيمو regardless of the status يعني سواء كان HR2 positive HER2 whatever. إذا كان عندنا life threatening disease then we start chemo عشان to reduce that tumor. أو fast growing tumor يكون عندنا high KI76 which is an indication إنه the tumor is growing so fast. الاندوكراين ما حنستخدمهم in combination with chemotherapy. حنبدأ أول شيء الكيموثيرابي إذا كان الكيموثيرابي indicated، وبعد كذا نبدأ الاندوكراين after that إذا كان عندنا HR positive أو hormonal therapy positive، hormonal receptor positive. في البريمينوبوزال of course women we will use الأوفيريان suppression therapy. في البيشنت اللي ما عمرهم قد أخذوا endocrine therapy حنستخدم aromatase inhibitor أو tamoxifen أو fulvestrant أو اللي هم ال CDK4/6 زائد aromatase inhibitor. إذا كانوا قد استخدموا قبل كذا hormonal therapy then we can use combination. نستخدم aromatase inhibitor مع CDK4/6 inhibitors. نستخدم مثلا aromatase inhibitor مع fulvestrant مع بالبو أو رايبو وهكذا. Sometimes we can use single agent إذا كان في contraindications أو البيشنت يعني in a very late stage. الأذر لاينز اللي احنا ممكن نستخدم نشوف التارجتس قد إيش في عندنا تارجت ل what kind of mutations do we have and we use targeted therapy accordingly. وآخر حاجة ال HER2 targeted therapy إذا كان البيشنت HER2 positive فحنستخدم تاكسان سواء دوسيتاكسل أو باكليتاكسل، يفضل الدوسيتاكسل وترستوزماب plus pertuzumab. إذا البيشنت failed this kind of regimen we can use a very new drug اللي هو تيسوتينيب زائد كابسيتابين زائد ترستوزماب. we can use ادوترستوزماب أو كابسيتابين لاباتينيب، أي واحد من هذولي in combination مع ترستوزماب. فغالبا ما حل. طيب can you please also نحل هذه الكيس. بنفس الكود. هنا في تباين كثير في الإجابة. طيب الجواب هنا حنقول إنه إيش ليش ما الترستوزماب زائد لأنه خلينا نقرأ الكيس عشان just طيب هي 60 أول شيء هي post menopausal women فما حنستخدم تاموكسيفين، حنستخدم aromatase inhibitor على طول أو any of the options. عندها metastatic عندها abdominal pain metastatic للليفر والكولون، فعندها visceral involvement. حنستخدم البيوبسي طلعت HER2 positive وهرمونال positive الاثنين، فبما انه عندها visceral involvement اذا لازم we have to start chemo. طيب وحنستخدم معها ترستوزماب مع البيست اوبشن في الترستوزماب ان احنا نستخدم تاكسان which is docetaxel زائد انه احنا عندنا HER2. فالHER2 هذا حنخلص اول شيء treatment of the patient with docetaxel trastuzumab وpertuzumab. لما تخلص التريتمنت هذا we can follow it up with for example any of the modules حقت الانستروزول. اوكي مثلا اللي هم الهرمونال ثيرابي. طيب that was it. In conclusion عندنا breast cancer is one of the most common cancer ranking second في الانسيدنس و fifth في المورتاليتي. early detection and through screening of high risk group هذا اللي best standard to reduce the mortality. السيرجري هي الجولد ستاندرد والتريتمنت في التريتمنت موديولز، واحنا كل التريتمنت الاذرز we want to push for surgery. hormonal receptors والHER2 status are the key components في systemic therapy. But now more targeted therapies are currently available to help better tailor therapy. Prolonged adjuvant therapy duration requires continuous monitoring. أغلب هذول patients أغلب هذه medications are teratogenic وعندهم يعني wide range of adverse drug reactions and drug interactions. But here is the role of pharmacy to start, we take actions in monitoring those patients, reducing their toxicity. Thank you.
Thank you, Dr. Ashtiaq, for this informative presentation and to the point presentation. I think we have here some question in the chat. Let's start with the first question. What is the option if the patient relapsed in letrozole after 2 years? This question from yes. Did you get the question, Doctor?
في الشات. It's okay. طيب.
Yes, yeah.
فهو بالنسبة طبعا هذا حيصير recurrent، نعامله كأنه metastatic cancer recurrent إذا صار progression after 2 years مثلا هو كانوا بيستخدم لتريزول أو أنسترازول. فوقتها حيصير في طبعا imaging، بنعمل imaging للبيشنت. we want to make sure إن هو ما هو metastatic just progression. we will do restaging، حيشوفوا فين موجود الديزيز. after that use إذا كان طلع still موجود positive HER2 positive أو HR positive disease, then we can use اللي هو زي ما كانت في السلايدات عندنا اللي هو CDK 4/6 inhibitors اللي هم البالبوسيكليب، رايبوسيكليب، اميباسيكليب. we can use it in combination مع الفلفسترنت أو يكون in combination مع الأروماتيز inhibitors أو tamoxifen. we can use it يعني يمكن قبل 4-5 سنوات ما كان في options غير إن إحنا نروح for chemo بس now في options. وطبعا we can use also إذا كان في البيشنت عندها BRCA positive سواء كان BRCA 1 أو BRCA 2 we can use targeted therapy BRCA for those patients. في واحد بيسأل what is the what about CA15.3 biomarkers. طبعا هذه البايوماركرز اللي هي الكانسر 15 أو كل الماركرز هذه بتتعمل قبل السيرجريز. بعد السيرجري we will notice very severe drop في البايوماركرز هذه. ويكون في regular follow up after that surveillance طبعا according to the guidelines 6 شهور بعدين يعني لها كذا schedule معين. وقتها حنشوف الديزيز هذا إذا ارتفع، إذا بدأ يرتفع level of those biomarkers, that means that there is a possibility of recurrence of the disease. So we will do investigations. We will see إذا كان في عندنا another kind of metastasis أو just progression. We will reevaluate the patient and start the therapy again.
Okay, thank you, Doctor, for your comprehensive answer. I think we are done now. Thank you very much, Dr. Ashtiaq. Thank you. Now we will move to our second speaker, Dr. Reem Al-Harbi. She is a board-certified oncology pharmacist from King Faisal Specialty and Research Hospital. Welcome, Dr. Reem. You can start now.
Thank you very much, Abdurrahman. Do you hear me now? Is the voice clear for you guys?
Yes, Doctor, clear.
Sure. Okay, so we'll start with the colorectal cancer treatment. The challenge actually will be to provide this topic in 30 minutes. So I'll try my best to give you an introduction of the topic, although it's a very huge topic. So I would recommend that for those who want to read further in it, they can go back for a student level for the pharmacotherapy pathology approach, a book, edition number 11, or to check the NCCN guideline. But mainly I'll focus here in briefly about the epidemiology, the etiology, risk factors, prevention and screening, clinical presentation and diagnosis, staging, treatment, and surveillance. So starting with the colorectal cancer is the third most common diagnosed malignancy worldwide, with fourth most common cause of death due to cancer. It's usually affecting male more than females worldwide. And there is several risk factors, including age with a median age for males around 67 years old, and for and for women around 62 years. And keep this in mind, because in the end of the presentation, we're gonna compare those with our local data in Saudi Arabia, and I want you to see the difference. As well as you can see that there is some other risk factors like development of polyps, and this is polyps, it's mainly the starting of the tumorigenesis or the pathophysiology of the colorectal cancer. We have as well inflammatory bowel disease and diabetes mellitus as a chronic disease that might cause colorectal cancer, as well as we have some hereditary syndrome like FAB or Lynch syndrome. So when you start with the tumorigenesis of the colorectal cancer, actually, it's usually start with the normal epithelium. And after that, it will start to have more cell division and causing of a small adenoma. The adenoma, usually it's benign. We don't worry about the adenoma. Although if they're getting larger and larger, it will lead to more increasing in the size, causing large adenoma, as well as it will lead to carcinoma. The carcinoma is mainly the cornerstone of the colorectal tumorigenesis, which further need to lead to metastasis. I want you guys to keep in mind here, there is some mutation that might happen during this tumorigenesis. The most common mutation you can see KRAS mutation and BRAF mutation, and usually we check for those for treatment in the metastatic setting, and we'll discuss this later on, as well as the microsatellite instability, and we'll talk about that further in the presentation. If you look at the prevention and screening, the chemo prevention usually, there is some data about diet, although it's not recommended yet. So some supplement like calcium, vitamin D, selenium, however, it's not well correlate with the prevention of the colorectal cancer, high fiber food intake as well. There is some references that they are saying it might prevent, but we don't have strong evidence to support that. As you know, there is data for the COX inhibitor that it will decrease the incidence of colorectal adenoma. Although due to the risk of cardiovascular event associated with that, we don't recommend using it as routinely for those patients. NSAID use, mainly the aspirin, it might lead to prevention of colorectal cancer, although there is no any FDA approval or NCCN recommendation to use this as a primary prevention for our patients. For the screening, actually, here I put for you guys the average risk patient, which is the normal patient, the healthy patients. Although if you're gonna go read further in the materials, you will see that there is certain specification for the high risk patient. So what I would want you to know, the age cutoff, it's usually 50 years of age or older to start screening for colorectal cancer, and it's very one of the most important screening for solid tumors, and usually the cornerstone to do colonoscopy every 10 years for those patients. For the symptoms, usually mainly change in the bowel habit. Generally, it's diarrhea or constipation, depends on the location of the tumor itself. With the rectal, usually you see bleeding, and this is the most common sign that our patients go to the emergency with rectal bleeding. As well, nausea, vomiting, abdominal discomfort, fatigue may present. For the general labs, those patients may involved with any, like presented with anemia due to the blood loss, and as well as we check for them the ECA, which is the tumor marker, but we took it usually as a baseline to see the response to treatment later on. So if you want to diagnose colorectal cancer, the cornerstone is to do colonoscopy with biopsy. So with the biopsy, it's the definitive diagnosis for colorectal cancer, and most of those patients presented with 92% with adenocarcinoma of the large intestines. Baseline lab, you have to do complete blood account with the differential. You have to do coagulation profile to make sure that your patient is not in bleeding risk, a liver and renal function for your chemotherapy to be started, as well as I mentioned, the CEA level as a baseline to see your patient response after starting the treatment. The staging, actually the colorectal staging is one of the unique staging in the solid tumors. Usually in the tumor, we check the size, although in colorectal cancer, we don't check the size, we check the depth of the tumor itself. So if you see here, we do the TNM staging. T start for tumor depth, and N start for the involvement of lymph node, and M if there is any metastasis. We divide them in stage 1, stage 2, stage 3, and stage 4, and this is mainly what I'm gonna discuss with you in the treatment. So in the treatment, we're gonna briefly talk about the early stage colon cancer, 1, 2, and 3, early stage rectal cancer, 1, 2, and 3, and combined metastatic colorectal cancer, stage 4. So when we get to the stage 4, the treatment is the same, but if you are in the early stage, it will be different. Okay, for the early stage colorectal cancer, colon cancer, let's start with this case and let me see your basic information about it. So Ines, are you with me? So this is RA, is a 55 years old Saudi man who recently underwent his first screening for colonoscopy. Colonoscopy showed several polyps. Biopsy was taken, showing adenocarcinoma of the colon. Metastatic investigation done, and it was patient negative for metastatic. We did for him the molecular testing on the tissue biopsy, question mark here, and it showed my microsatellite stable. The patient did the surgery, and he was negative for lymph node. He was T3. There was nothing high risk with this patient. So he presented to his medical oncologist, and he wants to know what's the treatment option he will have after done the surgery. He did the surgery, and his performance status is 1. So what do you think is the appropriate option for stage 2A colon cancer for this patient? So are you answering, guys? Okay. I got 80% of you answering this correct. Actually, it's the correct answer is D, which is observation. And we're gonna know now why the observation is the start or the treatment for those patients. So let's go. The observation is the correct answer. So keep in your mind stage 2 and observation. We're gonna talk about it in a minute. So for the early stage, we want to cure the patient. We do for them surgery with 12 minimum, with a minimum of 12 lymph node examined for the metastasis, and we do a chemotherapy mainly for colon as adjuvant, which is after the surgery to eradicate any remaining of the disease and improve the disease-free survival. Radiation has no role here in the colon cancer early stage. So usually we start 4 to 8 weeks after the surgical resection. Duration of treatment 3 to 6 months, depends on the risk. Treatment, we usually use the fluorobpyridine-based regimen as a single agent, 5-FU or capecitabine, or 5-FU with oxaliplatin. The benefit, it reduced the reduction, the risk for reduction was around 2.5 in stage 2 for recurrence and 25 for stage 3 for recurrence. we do check the DMMR, which is the microsatellite stability for stage 2, because it might affect their treatment. So in treatment plan, stage 1, we do the surgery. We say to the patient, you don't need any further treatment. Go for surveillance. And we're going to discuss the surveillance by the end of the presentation. For stage 2, those patient has a lot of talk, and there is multiple risk factors involved for their treatment. But for those without any surgery, stage 2A, without any high risk factor, as per the NCCN guideline, the risk factor includes several steps, and I listed below here in the presentation, in the slide, so you can go back for that. And for stage, we do the surgery and then we do the observation, because it seems that those patients, they do not benefit from the adjuvant chemotherapy, and they might do worse if we give them oxaliplatin. So for the first patient, we do only observation for them. For those with high risk, you might consider single agent chemotherapy as an adjuvant, either capecitabine or 5-FU. For those with MSI, DMMR, and no high risk factor, we do surgery for them and we tell them go for observation. Actually, those patients with the DMMR, they have genetic destabilization caused by the loss of DNA mismatch, and it's mainly associated with the colon cancer, and it's poorly differentiated. They notice from the data that those patients have a good prognosis, and they do not benefit from the chemotherapy. So you gave them the chemotherapy, there is no benefit, you may only give them side effect. So when we check for the DNA mismatch in those stage 2, we don't give them any treatment, we tell them go for observation. And you might check for other patients that MMR MSI, especially for personal history with colon cancer and metastatic setting, and we're going to talk about it in the metastatic. For stage 3 colon cancer, we do the surgery. After the surgery, it's recommended to give chemotherapy, and the treatment is either FOLFOX or COPOX, and we're going to talk about the adjuvant the chemotherapy regimen by the end. And for low risk, usually recommendation 3 months of COPOX or 6 months of FOLFOX. High risk, usually 6 months of COPOX or FOLFOX. It's category 1 recommendation. For the rectal cancer early stage, usually we want to cure those patients. We gave them surgery with 12 lymph node examined. Here we have the radiation play a very major role in rectal cancer compared to the colon cancer. So you might give them a new adjuvant or adjuvant chemoradiation, which is chemo concurrently with radiation, or you might give them a chemotherapy as a single without the radiation. So either to go new adjuvant or adjuvant, and as Dr. Shtia mentioned, the new adjuvant usually before the surgery, the adjuvant after the surgery. The chemoradiation option, we give them capecitabine with radiation, and the adjuvant and the chemotherapy option, we gave them either FOLFOX or COPOX. For the adjuvant, either to do a sandwich, which is chemotherapy, chemoradiation, and then chemotherapy, or to start with the chemoradiation and then chemotherapy. FOLFOX is the most common one used as adjuvant, and it's mainly contain oxaliplatin, 5-FU, and IV bolus and continuous infusion. So mainly those patients, they come to our infusion center, they take the chemo on day 1, and then we give them a pump, ambulatory pump, and we send them home for 46 hours with appointment to come back and disconnect the pump. The side effect, mainly, you will see peripheral neuropathy, you will see diarrhea with those patients, hand and foot syndrome, which is some of the skin toxicity, as well as neutropenia. If you don't have IV access or the patient wish to take the chemotherapy as outpatient setting, so we do COPOX. COPOX including oxaliplatin with capecitabine, which is the oral drug, and the prodrug of 5-FU, and those patients can take it orally at home. And the side effect, it's similar to the one with FOLFOX, although we see more diarrhea and hand and foot syndrome with the capecitabine. And those are the most common medication used in the adjuvant setting. When you combine with radiation, we usually give capecitabine single agent. We don't give oxaliplatin with radiation because it might increase the side effect and there is no benefit from it. And usually it's concurrent with the chemoradiation. On the days of radiation, you give capecitabine as oral chemotherapy. For metastatic setting, stage 4, let's start with this case, and I want to know your basic information. We have the same RA after 25 years from the treating his colon cancer. He came back to us with rectal bleeding, fatigue, weight loss, and constipation. The colonoscopy again showed poorly differentiated adenocarcinoma in the colon, ascending colon. His metastatic investigation showed liver mass, including 3 centimeters in the right lobe. We did for him the molecular testing, KRAS, RAS, and BRAF, and the microsatellite was stable. His performance status is 1. So what do you think would be the option for our patient to be treated with a right-sided colorectal cancer? He has stage 4 metastatic right-sided colorectal cancer. Okay, we have here most of you answer FOLFOX plus Avastin, FOLFOX plus cetuximab. The correct answer is FOLFOX plus Avastin, and we're gonna know why in a minute. Okay. So the metastatic colorectal cancer, usually the goal palliation, and you have treatment modalities surgery. Usually we use it as a primary for the primary tumor if there is any sign of obstruction, bleeding. Although colorectal cancer is one of the unique cancers that you can interfere with a curative intent, even in the metastatic setting. If you have a specific metastatic or isolate metastatic in the liver or lung, you can interfere and remove the metastasis from the liver, lung, and from the primary tumor, and you can aim for cure. Although the cure is 20 to 25%, but also we have a hope for those patients. Chemotherapy is mainly for palliation of the symptoms and prolong the survival by 6 to 24 months. As I said, for fluorouracil-based regimen is the standard of care. The chemotherapy here, whatever you used in the first line and the patient progress on, you can switch to the second line. It's like manipulation of the chemotherapy. There is no one better than the other. And radiation therapy as well here, it's for palliation if you have any pain or bleeding from the colon and rectal. So for the first line systematic treatment option, as you said, or as in the question that you choose, FOLFOX or FOLFIRI, wherever it's one of them, you can start with. Although it depends on the patient risk factor, tolerability profile. For example, diabetes patient with peripheral neuropathy, you don't want to give them FOLFOX that it might worsen their peripheral neuropathy. Although you have here some targeted therapy, which is include, for example, the anti-epidermal growth factor receptor, which is a monoclonal antibodies work in the epithelial growth factor and prevent the cell from dividing and inhibit the tumor growth. Those medication include cetuximab and blinatumomab. Why we didn't choose that in our patient before? Because it's right-sided. We had the NCCN recommendation and some data showed that those patients with right-sided colorectal cancer, they might not benefit from the MAP or the, EGFR inhibitor. So for that reason, most of the recommendation now going for those with left-sided. And the other most important thing that you have to know here, it's the RAS wild-type tumors. If we have any mutation in the RAS gene, that patient, they might not benefit from giving those medication for them. If the patient progressed on cetuximab, you cannot give them the blinatumomab, so they lost both medication. So we have as well the anti-angiogenic agent, which is the most common used and the most preferred when one based on the toxicity and the cost is the Avastin, bevacizumab. Bevacizumab actually it's used in a combination with either Cabox, FOLFIRI, or FOLFOX, or 5-FU in a first-line treatment, and it's showed improved response rate and survival outcomes. And those medication, the anti-angiogenic agent, the beauty about them as well, that if the patient progress on them, for example, like our patient, he was on FOLFOX and Avastin and progressed on that regimen, you can change to FOLFIRI and you can keep the Avastin, the bevacizumab, that it showed the patient they might benefit from giving the medication even if they are progressing on the previous regimen. So this is for the anti-angiogenic. We have immunotherapy era, which is now for the last 3 years is a lot of talk. The immunotherapy, actually, the beauty about it that it will turn on our immunity system to fight cancer, which will be against the cytotoxic conventional chemotherapy. Usually we give the conventional chemotherapy that it will kill the cancer. Now we are thinking the different, or we're thinking the opposite way. We want our immune system to be strong and go and fight the cancer. So mainly they will work on the T cell, and they activate the T cell, and this T cell will be hyperactive, and it will go and seek and for the hiding tumor cells, and it will go and kill those tumor cancer. So we have pembrolizumab as agent. It's used as a first-line treatment now, a new approval for those patients with MSI DMR, colorectal cancer. And in a second line as well, you can use bem nivolumab plus or minus imivolumab. If the patient progressed on one of them, you cannot offer the other one. So it's the same like the anti-EGFR inhibitors. We have some targeted therapy. I'm going to give you only a heads up about it, but if you want to read more, it would be good for you. We have some oral targeted therapy. We give them in a third line treatment if the patient failed 2 lines or failed bevacizumab, EGFR. We give regorafenib, which is a VEGF, oral TKIs. It's giving as a 160 milligram daily, and usually we recommend the patient to take it with low fat meal. The major side effect with this medication, hypertension, proteinuria, as well as hepatotoxicity. So you have to keep an eye on those. We have as well TAS 012. This is a conventional chemotherapy, but it's given as oral. It's considered for a third line treatment if the patient failed or prior line of therapy. Mainly you will see with them myelosuppression, and usually we recommend that they took the dose within 1 hour after complete the meal. Other targeted therapy, we have BRAF targeted regimen. Recently, it was added to the guideline that those patients have with colorectal cancer might have BRAF mutation, although it's occur around 5 to 15% in colorectal patients, but they offer them this option in combination with the EGFR inhibitors. HER2 regimen as well, it's an option for those patients, although it's non-FDA approved, and it's only 2 to 6% of our colorectal patients have HER2 amplification. So for the final case, we have this patient, RA, our patient, after a follow-up with the 12 months, it showed new progression in the liver region. But this patient was kept only on Avastin, bevacizumab, and 5-FU, leucovorin as a maintenance therapy. This is one of the things that they do, the physician. They don't like keeping the patient on oxaliplatin for a long time, and there is a stop and watch trial if you want to read about it. They can stop the oxaliplatin after 6 cycles of treatment and then to reassess the patient. So what would be the regimen for those patients, this patient for his progression after using the maintenance 5-FU with the Avastin? Okay. I understand that reintroduction of Folfox, it would be an option, but actually I would give this patient FOLFIRI and bevacizumab since it's within 12 months from the progression, which is a shorter period after the disease, after starting the original chemotherapy. So I would recommend for him FOLFIRI and bevacizumab. And as I said here, the continuation of bevacizumab would be as well an option for this patient. So just to summarize the metastatic, we have patient appropriate for intensive chemotherapy. We give those patients multi-agent chemotherapy in combination with bevacizumab or EGFR for those with KRAS, NRAS, or BRAF wild type. And for patients who are not appropriate for intensive chemotherapy, we can offer them a single agent chemotherapy with combination with bevacizumab or cetuximab, panitumumab, or immunotherapy. For the subsequent line of therapy, you can give them whatever they failed in the first line, you can substitute it with a second treatment, with the second line option. Here in detail, I put it for you guys. You can go back and read it. And if you have any question during that, I can answer you. So just to go over the surveillance. Here in the surveillance, actually, this is based on the stage, and this is based on the NCCN guideline. Usually they do for those patients colonoscopy, checking the CEA, and physical examination with lab to make sure that our patient is doing fine. And it might take up to starting yearly, every 2 years, and then every 5 years after the treatment. And it's different for colon versus rectal cancer. So to summarize, this is a retrospective analysis of Saudi cancer registry data. This is our local data for colorectal cancer. Colorectal cancer has been the most common cancer among men and the third commonest cancer among women since 2002 in Saudi Arabia. The incident was mainly in Riyadh and reached 14.5 per 1,000 population. The median age, which is strange, for male was around 60 years old, and for women was around 55 years old. So this is like, unlike the other we see in the international data, our women seems that they have a tendency for getting colorectal cancer at younger age. And the distant metastases were diagnosed about 30%, and mainly this represented in the rectal cancer presented of 41% of colorectal cancer. The overall 5-year survival was 44.6 for those periods. So in conclusion, colorectal cancer present at a younger age in Saudis, especially women. This has major implication on the decision about the threshold for age screening. Since we are getting patient diagnosed at younger age, the lower overall 5-year survival compared to the developed country may be due to the lack of screening, and with the higher proportion that we have advanced stage or metastatic stage as presentation, and that we don't have a lack of specialized care outside the major cities other than the capital cities and the major cities in Saudi Arabia. And thank you.
Thank you, Dr. Reem, for this comprehensive and informative presentation. Thanks a lot. I think we have some question here. There is a question, is colorectal cancer considered as metastasis?
I didn't understand the question, but what I can mention to you guys that colorectal cancer, it's either in the colon or in the rectal, and usually it's depends on the stage, from stage 1 to 3. But when we reach to the metastatic setting, we deal like a colorectal cancer as a single entity for treatment. So I didn't understand what metastasis mean, but it's either affecting the colon or affecting the rectal, but depends on the stage of the disease, how we're gonna treat the patients. Is that clear, or?
I think it is clear. I think it's clear now. Any more question?
I hope they benefit from the presentation. Presenting colorectal cancer in 30 minutes, it's not an easy job. So I hope, guys, you grasp as much as you can from the information.
Thank you, Doctora. And mashallah, you did it, 30 minutes.
Thank you very much.
Okay, thank you, Doctor. I think now we are done with the second presentation. Thank you all, Dr. Reem. For now, we are going to go with the third presentation, which is pharmacotherapy of lung cancer. It will be presented by Dr. Abdelmajid Al-Nacha. He is a board-certified oncology pharmacist, a clinical pharmacy specialist in medical oncology in King Abdulaziz Medical City in Jeddah. Welcome, Dr. Abdelmajid, and you can start. Good luck.
Assalamu alaikum wa rahmatullah. Assalamu alaikum wa rahmatullah wa barakatuh. Hopefully you can hear my voice clearly.
Wa alaikum assalam wa rahmatullah. Clear, Doctor.
It's my pleasure actually to be here with you today. I know it's not easy to give a presentation after two excellent presentations. Initially, let me thank the SOBA and the organizing committee for giving me this opportunity to present lung cancer to you this evening. So by the end of my presentation, hopefully you will be able to differentiate between lung cancer types. We're gonna talk about small cell, non-small cell lung cancer, and then we will subdivide those into different subtypes. Also, hopefully you will be able to list and memorize risk factors associated with lung cancer. Then we're gonna discuss treatment options for small cell and non-small cell lung cancer based on histology, presence of driver mutations, and programmed death ligand or PD-L1 expression. Let's start with a brief background about lung cancer. Lung cancer originating from the bronchial epithelial cells in the lung. It may be referred to, or we can have two types of lung cancer. We have small cell lung cancer and we have non-small cell lung cancer. Although small cell lung cancer and non-small cell lung cancer sharing many characteristics, however, they are treated differently. The incidence for non-small cell lung cancer is the second to prostate cancer in men and to breast cancer in women in the United States. Non-small cell lung cancer and small cell lung cancer are the leading cause of cancer-related death. Smoking is the biggest risk factor for lung cancer. We will talk later about other risk factors as well. This slide shows the most common cancers in Saudi Arabia in 2013. Lung cancer ranked the 5th among males and 15th among females in Saudi Arabia in 2013. Male to female ratio is 3:1. So for lung cancer patient, we have around 75% are males and 25% are females. And we can see, like, for example, the incidence of lung cancer in Saudi Arabia in 2013 was around 430 new cases at that year. Here we can see the age-specific incidence rate of lung cancer in Saudi Arabia. As expected, it will be rare in the childhood because the incidence will increase with time because the increase of the like exposure, for example, to cigarette smoking and other risk factors. So with age, we will have increase in the incidence. At the childhood, there is rare, or there is no lung cancer, we can say. With age, okay, with time, we will have increase in the incidence. The median age at diagnosis was ranging between 66 and 74 years for male and female. So this is the age where mainly patients with lung cancer are diagnosed. This graph shows that the distribution of lung cancer in Saudi Arabia is stage distribution. Unfortunately, the majority of the patients are with distant metastasis. So they are with metastatic disease. So this means we cannot cure those patients. because as we will discuss later, patient with metastatic disease will be, our goal of treatment will not be curing the patient. So unfortunately, the majority of the patients are having metastatic disease. To understand cancer in general, we should have like a brief knowledge about the difference between normal cells and cancer cells. So this slide will show briefly the difference between normal cells and cancer cells. For normal cells, the normal cells increase in number when they are needed and die when old and or damaged. So this is important. They die when they are old or damaged. There is something called apoptosis or the programmed cell death. So the cell will have certain lifespan, certain lifetime. After this time, the cell will die or damage. In contrast, cancer cells quickly make new cells and live longer because of the abnormal changes in genes. So in the normal situation, the cancers or the cells will die at certain point. In cancer cells, cells will continue to divide and proliferate, and then cancer will form. And this is an important concept because this is how cancer will have a size, because we have like divided or uncontrolled division or proliferation of the cells. In order, this is an important slide. I actually, when I put this this lecture or this presentation together, it was a challenge because I need to meet the need for the audience. So I know maybe I need to make it like as simple as possible. So I try to simplify it as much as possible. So if we look on lung cancer, we can make it into two types. We have non-small cell lung cancer and we have small cell lung cancer. Then further, for non-small cell lung cancer, we can divide it into two subtypes, like non-squamous or squamous cell, because this will be important when we are discussing the treatment options. For non-squamous, we can divide it into adenocarcinoma, large cells, and other types or other cells. So focus please on this. Lung cancer, we have non-small cell and small cell lung cancer. For non-small cell lung cancer, we further subtype them to non-squamous, which include adenocarcinoma, large cell, or others, and we have squamous because the treatment is totally different. Also, in order to understand the management of lung cancer, we should be familiar with lung cancer histology. We can divide, like I said, by lung cancer. We have small cell lung cancer, which represent 15%. So small cell lung cancer represent 15% of the all lung cancers, and non-small cell represent 85%. If we took, for example, the adenocarcinoma, which is one type of non-squamous, non-small cell lung cancer, it represents 50% of the total lung cancer. Squamous will represent 30%, and the other types and large cells will have 5%. So keep this in mind. So for that reason, we are seeing the majority of patients with non-small cell lung cancer. Now we are moving to the risk factors. As you can expect, cigarette smoking is responsible for approximately 80 to 85% of lung cancer cases. And cigarette smoking particularly is important because it's a modifiable risk factor. What does that mean? This means we can modify it. Sometimes with certain types of cancers, we have risk factors that we cannot move. For example, Dr. Ashiag spoke about or present breast cancer. Female gender is a risk factor for being or for having a breast cancer. However, this is something we cannot change. Sometimes age is a risk factor. Also, we cannot change. But cigarette smoking, this is a modifiable risk factors. So for people who are smokers or who are smoking, then we need to offer them smoking cessations in order to minimize and reduce the risk of developing lung cancer. Also, environmental exposure. So especially people who are working in like painting, dealing with dyes and asbestos, benzene, or arsenic, they will be at high risk of developing lung cancer. Ionizing radiation, also I didn't mention it here, but it's one of the risk factors, genetic risk factors, and also history of other lung disease such as COPD, asthma, and pulmonary fibrosis. So all those are risk factors for developing lung cancer. However, cigarette smoking is the biggest one. So how those patients present? Actually, the initial signs and symptoms vary according to the location and the stage of the disease. Many patients are asymptomatic upon initial diagnosis. So sometimes patients might present with lung cancer, however, they don't have any symptoms. Sometimes those signs symptoms may be masked by other concurrent conditions like COPD, asthma, or other lung diseases. As you can expect, because lung cancer, this is a disease or this is a type of cancer which affect the lungs. So we can see patients with respiratory symptoms like cough, dyspnea, chest pain, or discomfort with or without hemoptysis. Also, patient might have some symptomatic or some systemic symptoms such as anorexia, weight loss, and fatigue. So usually when we are talking about weight loss, we are talking about losing 10% or more of the weight within 6 months. Of course, this lose should be involuntary. So sometimes maybe people will be at certain type of diet or exercise, they want to lose the weight. Well, it's not counting here, but losing weight with certain limit above 10% of body weight within like certain time frame, this might be an alert. Lung cancer can spread or can metastasize to different organs like brain, bone, and liver mainly. So if patients present, and we have a good amount of patients will present with metastatic disease upfront. So patients, they don't know they have a cancer. When they present with a metastatic disease. So if this patient have like, for example, brain mets, so patient might have neurological deficit. If the patient have bone mets, so they might present with bone pain or pathological fractures, liver dysfunction from hepatic involvement as well. Also, a paraneoplastic syndrome may be the first sign of the underlying malignancy. Examples are cachexia, hypercalcemia, we call it hypercalcemia of pregnancy, syndrome of inappropriate antidiuretic hormone secretion, and Cushing syndrome. As you might know, those symptoms we cannot diagnose the patient based on those symptoms because they are not specific. So we need to combine those symptoms with other like radiological findings, other biopsy in order to confirm the diagnosis. Lung cancer screening. First, let me give a brief about the screening. When we are talking about screening in cancer or screening for cancer, we are doing the screening not for patients. We are doing the screening for people, for normal people, in order to detect the cancer in early stage in order to cure. So we have different types of solid tumors. Not all solid tumors having a recommendation for doing screening. And why is that? The screening is important. Screening for cancer is important in the types of cancers where we can reduce the mortality. So for example, as we'll discuss in the next slide, lung cancer screening will reduce the mortality. For example, breast cancer screening also will reduce the mortality. Screening for colorectal cancer will reduce the mortality. So we are doing screening. But for example, for head and neck cancers, there is no evidence that the mortality will be reduced. So no need for screening, because when you are telling screening, screening means doing tests or procedures for the whole population in order to detect the cancers early. So National Cancer Institute, or NCI, back in 2002 launched a large clinical trial. They compared the CT versus the chest X-ray in order to screen for lung cancer. Their patient or their people was having current or previous heavy smokers, age 55 or more, having 30 back year of smoking, or former smoker who quit within the last 15 years. The findings of this trial was important. They found like there was 20% fewer lung cancer death in those screened with CT scan, and 7% reduction in all-cause mortality when screened with CT. So for that reason, the US Preventive Service Task Force, they are recommending to have annual screening with low-dose CT for people who are aged from 55 and 80 and have a smoking 30 back year history, who are currently smoking or have quit in smoking in the past 15 years. Of course, also they recommend to discontinue screening if the people knows or didn't smoke for the last 15 years, have any health issue limiting the life expectancy, ability or willingness to undergo curative lung surgery. Why is that? For example, if we have someone like we have a 75 years old male and we want to screen for lung cancer. Let's say this gentleman having a situation which will prevent him from having surgery. So he's not eligible for surgery. So then even if we detect an early lung cancer, we need to do surgery in order to resect the lung cancer to cure the patient. If surgery is not possible, then what's the benefit of knowing that this gentleman having a lung cancer? So we need to have a curative intent, or patients need to be eligible for a curative intent in order to do the screening. So let's have our first case. So GH is a 67-year-old retired nurse, social history, caring for her father. She started smoking at the age of 17 and quit at the age of 59, smoked 1 pack per day. So she has smoked for more than 40 years. She is discussing with her doctor the lung cancer screening. So now the question is this patient or is this lady candidate for lung cancer screening or not? Please make my evening and give the right answer for this one, because the answer is in the previous slides. Okay, I'm happy. Yes, I agree actually with 60% of you who answered, yes, this patient is a candidate for screening. But first we need to know why A is not the right answer, because I just show you in that trial that when we compare CT scan to chest X-ray, the CT scan show reduction in the mortality. So the standard of screening is the CT scan. The C is not the right answer, because this patient, we said in the based on the criteria from the trial and the recommendation, patient, if they quit less than 15 years, we need to include them in the screening, and the amount of fallback also is not applicable for the patient. So now let's move to the clinical staging for non-small cell lung cancer. Now we are talking about non-small cell lung cancer. For non-usual in solid tumors, we are staging or clinically staging the cancer into 4 stages, from stage 1 to stage 4. I think Dr. Ashjiak present a slide describes this in more details. So generally speaking, almost all solid tumors, we are staging stage 1 to stage 4, while stage 1 usually is the early stage, stage 4 is the metastatic stage, okay? In order to do so, and sometimes also we have number or we have letters besides. So this is stage 1, A or B or C sometimes, and so on. In order to do this staging, we need to know the TNM system. TNM system This is a system used to do the staging, usually done by pathologists. T will stand for the size of the tumor. N will represent the lymph node involvement, and M if we have or if there is metastatic or not. So for example, for stage 1 non-small cell lung cancer, the tumor is the 5 centimeter or less, so this is the T, or this is the size, okay, and there is no nodal involvement, so N will be 0, M will be 0, so this is stage 1, and so on. I will not go through all of these. For example, for stage 4, we have a distant metastatic disease. Now we will move to lung cancer treatment. Initially, when we start treating or having treatment plan for lung cancer patients, we should focus on the goals of treatment. It's vitally important to know our goals of treatment. So in early stage or for early stage disease, our primary goal will be curing the patient. So this is our wishes, this is our hope, try to cure the patient. But unfortunately, this is not the case in advanced stage. So in advanced stage, our goal will be shifted toward prolongation of survival. Why it's important to know our goal of treatment upfront? Because this will matter. Like for example, if there is a patient who is on chemotherapy, like I have 2 patients on chemotherapy, the first patient, and they both have toxicity from the chemotherapy. But the first patient, I'm trying to cure the patient. Second patient, this is a palliative chemo, so I'm just giving for palliation. If both patients develop toxicity from the chemotherapy, for first patient, I want to keep the density and intensity for the chemotherapy, even if there is like certain type of toxicity, because I'm trying to cure the patient. However, I'm trying to give the chemo, for example, on time and keeping the same doses, full dose, not to do like, for example, dose reduction. However, if my aim is to prolongation of survival, or what we call it palliation or palliative chemo, then I might delay, for example, the cycle. I might do like dose reduction. So this is important to determine our goal upfront when we have a patient. Now we're gonna start with the first type of lung cancer, which is small cell lung cancer. Key points to keep in mind when we are talking about small cell lung cancer, those types of cancers have a higher proliferation rate than non-small cell lung cancer. So if we compare it to the non-small cell, they having higher proliferation rate. They are very sensitive to radiation and chemotherapy. Why they are very sensitive? Because the proliferation rate is high. And as you learned in the previous few days when there was a talk about the pharmacology, radiation and chemotherapy will act more on the highly proliferative cells, okay? So small cell lung cancer is very sensitive to radiation and chemotherapy. Systemic chemotherapy is the backbone for treatment of all stages. We are using systemic chemotherapy, and surgery has almost no role in small cell lung cancer, so no role for surgery. The overall, or the 5 years overall survival is around 5%. So this means if we have 100 patients today with the small cell lung cancer, we can expect only 5 patients will stay alive after 5 years. And this 5 years overall survival for limited stage will range from 10 to 13%, and extensive stage 1 to 2%. Usually, like I told you previously, in the non-small cell lung cancer, we are staging the non-small cell lung cancer from 1 to 4. The exception usually in solid tumors, when we are talking about staging of small cell lung cancer, we have 2 stages. We have limited stage and extensive stage. For the limited stage, the goal of therapy is a cure. We try to cure the patient with a cure rate of 20%. Usually limited stage, this means we can confine the tumor in one radiation field. The treatment, we are treating with concurrent chemoradiation. So we are giving chemo and radiation together. Chemo usually standard is cisplatin etoposide with concurrent radiation for 4 to 6 cycles. For extensive stage, the goal of therapy is palliation. Unfortunately, for extensive stage, we cannot do the cure or cannot cure the patient. So we shifted our goal to palliation. The median survival without treatment is only 5 weeks. So if we have extensive stage small cell lung cancer, if we not giving any type of treatment like chemotherapy, for example, patient only will live for 5 weeks. And this might extend to around 10 months with platinum doublet. The treatment options for extensive stage is cisplatin or carboplatin-based combination chemotherapy for 4 to 6 cycles. For long period of time, for almost 30 years, this was the only options for those patients. Now, recently, there was a new approval of first-line treatment when we have the immunotherapy, when we have this checkpoint inhibitors. So atezolizumab plus chemotherapy, which is carbo and etoposide for 4 cycles, followed by maintenance atezolizumab. This give 2-month improvement in the overall survival and 1 month in the progression-free survival. And just want to mention that I didn't put it here, but want to mention there is a role for radiation here if the patient having like symptoms. So like brain symptomatics, we can give radiation before or after the treatment. If patient having any CNS symptoms, we will give the radiation before the treatment. If the patient with no symptoms, we will give chemo. After finishing, we will start the radiation. For second line, this means, what do we mean by second line? Second line, this is if we have a patient who failed the previous line, like the chemo that we discussed in the previous slide. We need to know the timing. So time either will first option will be clinical trial. The other options, we need to know how much the patient or how much the time between completing the previous line or the first line and the disease recurrence. If this time is less than 6 months, then we're gonna use those agents considered as second line agent like topotecan, irinotecan, taxanes, and also we can use the immunotherapy. If this time is more than 6 months, then we're gonna repeat the initial regimen. We consider this patient is sensitive or platinum sensitive, so we can repeat the initial treatment. Now for our second case, ML is a 59-year-old man in emergency department with a new diagnosis of extensive stage small cell lung cancer. He smoked 2 packs per day for 27 years, quit 5 years ago. So this patient brought by the family to emergency department. He is disoriented, has family reports receiving erythromycin for bronchitis 2 weeks ago, hasn't eating and having experienced involuntary weight loss. So the labs are almost normal. So the question is, what treatment option you will suggest for this patient? Okay. طيب. It seems this was a difficult question for you. So I agree with 29% of you. Some of you choose the, okay, I will go one by one. Sorry. So the correct answer is the carboplatin etoposide. We said this is the standard of care, carbo etoposide for 4 to 6 cycles. Number 1 is not the correct one because this is the number of cycles and because of the it's missing etoposide. Number 2 is not correct because we are not using concurrent chemoradiation with extensive stage. This is extensive stage. If this was early stage or limited stage, this might be a correct answer. So the answer D is the most appropriate answer. For the sake of time, I will try to speed a little bit. Now we are shifting to the non-small cell lung cancer. Key points to keep in mind when you are dealing with non-small cell lung cancer: surgery, radiotherapy, and chemotherapy are all modalities used in the treatment. Treatment is individualized according to the disease stage. to the tumor histology like adenocarcinoma, squamous, or large cells, the presence of molecular mutations or driver mutations like EGFR or ALK, PD-L1 expression, the performance status, comorbidities, and patient preferences. Keep in mind, for example, performance status is important because people or patients with poor performance status, they will not get benefit from chemotherapy. So this slide summarizes the treatment options for non-small cell lung cancer. احنا حكينا انه that we have stages from 1 to 4. We can also group those stage 1, 2, 3A into as resectable and unresectable, which is 3B and stage 4. So for resectable tumors, surgery is the cornerstone because we want to take the tumor out. So we are doing surgery followed by something called adjuvant cisplatin-based chemo. So we need to give adjuvant chemo in order to eradicate the micrometastases. Radiation sometimes used in this setting if the patient is not eligible for surgery, and we will try to cure the patient. For unresectable, we have stage 3B. So we are using combined modalities, platinum-based chemotherapy plus radiation therapy, and we might consider consolidation with durvalumab. And then we have stage 4. Just a brief when we are talking about adjuvant treatment. So this is for resectable patient. We're gonna do surgery. After surgery, do we want to use adjuvant treatment or not? Based on the stage. So for stage 1, no adjuvant treatment recommended, and no radiation adjuvant is recommended as well. So we use the adjuvant treatment only for stage 2 and stage 3A. Here we can use only adjuvant cisplatin-based regimens. Now we move to stage 3B, non-small cell lung cancer, cisplatin-based chemo plus radiotherapy. Our aim from this is to try to downstage the tumor in order to have surgery or in order to have resection and try to cure the patient. Consolidation also with durvalumab, this make like a good advance in this setting in stage 3B. Now we are talking a little bit about unresectable or metastatic non-small cell lung cancer. Our goal of treatment here will be improve quality of life. So we are not curing the patient anymore. So we want to improve the quality of life, improve the median survival, reduce disease-related symptoms. We are using usually 4 to 6 cycles of chemotherapy. Usually this is platinum-based, and we can use maintenance treatment later, like usual maintenance will contain different strategies like continuation or switching. So we can give single agent. It's important to know about the mutations in lung cancer. We have many mutations not known, and we have known mutations. Some of those mutations we have target, or we can target those mutations with medications. So EGFR, ALK, ROS1, and other, those are the targetable mutations. And this is the prevalence of those mutations. And those are the drugs. What's important is those mutations that we have drugs that can target those mutations, like, for example, EGFR TKIs, ALK inhibitors, and others. So a few years back, we wasn't having that much options for those patients. However, if we look on the guidelines, we having many options. So for example, if we have advanced or metastatic disease, non-small cell lung cancer, we need to do molecular testing. Based on this testing, we will give the treatment if there is a mutation exists. Again, just want to remind you, because I will summarize the treatment. I know maybe it's get confused a little bit for you. The last 2 slides will summarize the treatment options. So just remember, we have non-small cell and small cell. And for non-small cell, we have non-squamous, squamous. Those 3 types, like adenocarcinoma, large cells, are under the non-squamous, and squamous cells by its own. So we will start from here. If we have a patient, okay, with non-squamous cells, then we will ask our next question: is there any targetable driver mutation? If the answer is yes, then we want to target that mutation with for example, TKIs, if we are talking about EGFR. So this is the first line. If patient failed this line, then we're going to second line, either will be chemo or osimertinib, for example, if this is T790M mutation. If patient failed here, then we have chemo options. And for ALK rearrangement, the same. We will use ALK inhibitors like alectinib or crizotinib. This is now the preferred agent. Just want to tell you those tables just for your information. It's not updated. This is just because we have more updates and we have more agents in the groups. Just this is to illustrate to you how we are thinking. And if this is 0C1, we will go one by one, first, second, and third line. If there is no targetable mutation, then we will think about the PD-L1 expression. If we have PD-L1 expression more than 50%, then we will use the immunotherapy like pembrolizumab, and we have atezolizumab now. If this less than 50%, we'll start with chemo. For second line, also we have now chemotherapy like platinum doublet, and third line we have docetaxel, for example, in this setting. So this is in case of non-squamous. Now we are moving to the squamous cells. Squamous cells, we will ask this question. Usually for squamous cells, there is no mutations. And if we have squamous histology, then we are not testing for mutations unless there is like mixed histology, or there is the patient is never a smoker, or there was a small biopsy. So for squamous, we are measuring for PD-L1 expression. If we have PD-L1 more than 50%, then first line we can use like immunotherapy like pembro. Second line, we can go for platinum doublet. And if the PD-L1 less than 50%, we can go for platinum doublet, immunotherapy in the second line, and so on. This is how it looked like now in the NCCN guidelines. We have many options offered for those patients. So based on the targetable mutation, this is why we call it targetable mutations, because we have agents which will target that mutations. So now let's go quickly for the third case. So this is a 74-year-old female having adenocarcinoma. So with liver mets, so this is a metastatic adenocarcinoma, non-small cell lung cancer. This patient found to have ALK rearrangement positive and PD-L1 less than 1%. So what's the, I know that maybe the question is not there, but I think it's obvious the question, what's the best treatment option for this patient? Okay, actually, I agree with 19% of you. I know this is difficult from the first time to get it clear or right, because if we refer to the patient, this is ALK positive, and we said that if we have a mutation, we will target that mutation. So this patient has an ALK positive or ALK rearrangement. So we should use alectinib, which is the medication, or which is the ALK inhibitor. This erlotinib, osimertinib are used for EGFR for different type of mutations. Pembrolizumab, it will be used later maybe in the treatment, or if there is no driver mutations. The last slide, just want to emphasize that it's important, but for the sake of time, didn't include the toxicity of chemotherapy. But usually, because we are using cisplatin or platinum-based, especially the cisplatin, we need to keep in mind the nephrotoxicity caused by cisplatin. So we need to give hydration, and also we need to replace electrolytes. And cisplatin, as you know, it's known to have causing chemotherapy-induced nausea and vomiting, acute and delayed. So we need to take care of patients. Thank you for your listening. If you have any question, and sorry to exceed the allowed time.
Thank you, Dr. Abdelmajid. Thank you. Thank you for this comprehensive review and very excellent overview of treatment of lung cancer, both type small cell and non-small cell. For the question, Let's see if there is any question.
Any question? Hopefully it was clear and there is no questions.
No, mashallah, it seemed it was very clear for the audience. I think we are done, Doctor. There
Thank you
is
so
no
much.
more question. Thank
And
you,
sorry
Doctor.
for
Thank you very
difficulty
much.
and late. Yeah, you are welcome.
No, thank you. Thank you very much, Doctor, for your presentation. And actually, I would like to thank all of the our speaker today, Dr. Areem, Dr. Ashtiyaq, and Dr. Abdul Majid. Thank you all, and many thanks for our audience. I hope you get benefit from this course for today. So, inshallah, we will see you tomorrow, our fourth day. At the same time, we'll start at 8 up to 10 p.m. inshallah. Thank you all.